joining us. I see some familiar names and faces and that. And so thank you for taking time out of your busy day. And thank you to BC Care Providers for giving us the opportunity to be able to share our experience in that. You may see my head go to the side. I've got two screens, so trying to look at people and also look at my presentation and that. I hope you can all see the slides in that now. And so I'm Lisa Samms-Maxwell, and I've been with Langley Care Society for almost 10 years now, as their director of care. And currently I've moved into a position as director of quality research and innovation. And joining me today, I'm so lucky to work with this lady, Mary Gerali, and she's the acting director of care at Langley Lodge, and brings a wealth of knowledge and experience in long-term care with her. And, we have a lot of fun and a lot of challenges, as we'll talk about some of that in the presentation. Hold on, I can't even see my little thing for clicking. Hold on. Okay, again, we are coming from Langley, which is on the unceded traditional territories of the Coast Salish people. And we acknowledge and thank the people that have taken care of these lands, and that's the Kwantlen, Matsqui, and Semiahmoo First Nations. So we're talking about leveraging technology in long-term care, and that's not something that necessarily long-term care has been known for. And I think most of us, the most we've done with technology, and this is more with the affiliate homes, and that is using our electronic health records, when we all kind of converted from a paper base to point click care or another electronic health record. In that, we started looking at technology when there was some concerns that were brought to us from staff. Specifically, our physiotherapists and our frontline nurses were coming to us because they felt they were facing ethical issues and were having to make decisions about resources for people, about who got resources, who didn't get them, and how did we distribute them. And so specifically, we're talking about beds with, alarms for falls. So we had maybe about 20 beds that had, built-in alarms, whereas, we're a home kind of, we're considered a medium-sized urban home with 139 residents that reside with us. And all of them have complex care issues and that. And so what we were noticing in the last few years, and I'm sure any of you are coming from the experience of a long-term care facility, was that the acuity of the residents that were being admitted and the fall risks, their frailty scores and that were much higher. And so because we didn't have those beds, we did try to look at some solutions in that. And we did end up trying many different alarms and that, and a lot of them were quite noisy and caused discomfort and disruption to the residents, which, if anything, further increased their fall risk. And when we looked at beds, and we even had some beds brought into us, and I mean, I really respect the people that did that for us. We were looking at, multiple beds and that, and what they were bringing to us just really resonated with acute care. They had all the bells and whistles, they had the lights underneath, which is helpful, but they had places for kind of, people to put their iPads. We at Langley Lodge come from a philosophy of person-centered care, but also a palliative approach. This isn't the kind of technology that we require. And so the beds we were seeing were not appropriate for the population that we were serving. So we were looking for something that we could utilize with our existing beds, or technology, that would tell us when people were exiting their bed. We could check We could check it from a central location. You know, we were kind of looking for something that was not a wearable, non-intrusive. So we kind of had a long list of what we were looking for, and then we did talk to a company, and I'll tell you more about this company later. But they kind of ticked all the boxes, but also gave us a lot of things that we weren't looking for. So it was a real value added experience for us. And I haven't had this experience when I talk about other technologies and meeting with vendors and that. Lots of times people are looking to, you know, promote or sell their product. But this company in particular was talking to us about what are your needs? What is it that you're trying to measure? What is it that you're concerned about? Oh, sorry, didn't mean to go there yet. So the great thing about this technology, and you can see in this picture here underneath the bed on the corner, let's see if I can do that without switching the pages right here. There's this little device goes under here. And so that's about as non-intrusive and non-wearable as you can get. And what this could do, it gave us reports on people's sleep quality. And this company, Talk Tech, they were looking at sleep quality, but their technology also allowed for us to see the heart rate of the residents, their respirations. We could see when they were exiting the bed. We could see when they were getting back into bed and that. And the beautiful thing about this, and this is what we're all going to be working on in the future, is how do we integrate all these different solutions and technologies and that? And this also was integrated in with our nurse call system. Now, the other thing I would say to you is why this was really appealing to us as an organization was our nurse call systems currently are so antiquated. With so many people in long-term care living with dementia or physically not able to, you know, press the button to call the nurse and that. The nurse call system, it just isn't functional. We find most of the time, and I'm talking from just our professional and personal experiences, that it's family members that are using the call bell system more so. So this actually allowed us to be able to monitor our residents in their rooms, no video or anything, in a non-intrusive way, and allowed us to, you know, provide care in an efficient manner. So, like anything, you know, you're a bit nervous. It's brand new. We hadn't really heard of this type of technology, Sleep Sense. And so we wanted to try it. And so we started our trial in January, February of 2022. So that's actually becoming a long time now. And we first started with 12 beds. We identified people with a fall risk and that. And we first started it kind of on the 12 beds that were throughout our facility. Our facility is like 6 stories. And so we quickly had some learnings in that when you have dual systems in play, it's very hard for staff to learn it. So we eventually put our starting residents in the program all on the one home area so that it was easier to work with the staff that were working on that home area. We do cohort our staff too, so it's the same staff that are working days, evenings, and nights and that, and they rotate through on the home areas and that. We quickly found that this was very beneficial. It worked. It didn't disrupt the residents and that the training was pretty intuitive. What I found was that, like most of us, you'd be hard pressed to find a person now who doesn't have a smart device, a smart telephone. So it's becoming easier. I remember many years ago when I was doing electronic records in public health, and nobody even had smartphones then, and just teaching people how to turn on computers. Well, most people now, no matter, you know, what your age or background, have, you know, a computer or at the very least a smartphone. And so the training we did with the staff on how to navigate the system was intuitive. And the staff had lots of really good questions. And one of the things I would say to you, though, is that we did miss not doing the training with our housekeepers. And it's really important that everybody understands. So our maintenance, they help with the maintenance of our technology and that. But with our housekeepers, the reason it was important was they actually, as you know, we're changing out our beds, once, twice, three times a week. Well, the staff were moving the beds and they were actually causing some damage to the devices. Our rate of damage has gone down substantially. They're not pushing the beds up against the wall anymore. So it's the little things like that that you sometimes forget. So everybody, you could ask anybody in our facility now, and they'll know what Sleep Sense is and what it does for everyone. So we did that little bit of a soft launch, as you can say, and that. But what was really amazing is when we worked with Jessica at Talk Tech, we were actually able to develop something that Mary will talk a bit more about, virtual rounds. And so whenever we look at technology, it's not just about, the primary is how do we care for our residents, but it's also about not adding more administrative burden to our staff and how can we help our staff in doing their work. And I think, as most of you know, we have our least amount of staff usually on site on our night shifts. So it's really important that they feel supported. But also, I would say that our physical rounds lots of time are what I call a non-value added tasks that people do, going from room to room with their little flashlight, frightening people and that. But we also found that it wasn't actually accurate. We had some residents who were saying they weren't sleeping. And when, we went back and looked at it, they were actually not sleeping, even though if I looked at what was documented and observed by the staff member, they said they were asleep. So they weren't opening their eyes, they weren't acknowledging them every few hours. But so now we have kind of better documentation, and our staff, we'll talk a little more later about the staff response and that to this process. What we did find at 4 months, we did our initial evaluation and that, and we did see that we got a 23% reduction in our falls, 25% time savings for our night care staff. So now they were no longer going with their little flashlights. Later, Mary will show you, they could actually do a virtual round by opening up the computer, like opening up a program in the computer, and they could see exactly who was sleeping and who needed maybe some care. So on our home areas, we have 26 residents. If 23 of them were sleeping and 3 were awake, that's the 3 people that she would prioritize to go and see if what they might need. We did notice that over the 4 months that our residents' quality of sleep improved by 35%. Now, do we have a direct correlation to that? Not necessarily, but I think when you build people's awareness at a conscious and a subconscious level, they start looking at sleep. And we were asking people to document about sleep and that. And then we found that with Sleep Sense 2, because we were looking at people's sleep, we also seen a reduction in responsive behaviors. Again, is that because we're working to help people improve their quality of sleep? I don't know about you, but I can be a grumpy bear if I don't get a good night's sleep. And if you do it several nights in a row, the grumpiness just increases and that. So when we did do our staff survey, 67% of our staff they felt more supported in their work on night shift, which was really nice to hear. And like I said, when we initially went looking at this, we weren't necessarily looking at will this be a substantial improvement for staff, but it came from a clinical need. So I talked a little bit about this. So with the Sleep Sense program, falls were now, we could tell when people were getting out of bed and that in real time, and that was going directly to the nurses and care aides' phones, and that we were closely monitoring falls, which we all do, and that. And we were using our sleep data to understand what people weren't getting a good night's sleep and if they were had a fall risk and that. I've already talked about how they weren't going into the room with their flashlight and there was, nobody disrupting their sleep. But we actually didn't have a policy around rounds or documentation of rounds before this project. That wasn't at Langley Lodge. I had been there for 7 years previous to that, and there was nothing. Now we have documentation, and that not only can we see that the staff did a round, but lots of times they'll make a note. Oh, Lisa's up, she's sitting in the chair, she's just having a little snack and going to go back to bed. So I've never even seen that kind of stuff before documented when people were getting up at night. It was more, and I think anybody in long-term care knows once one person's up and walking through the halls, and if they're wandering into other people's rooms or if they're talking loudly, then you're going to get more people. It's like a domino effect, really. And that. So we felt that, with this integrating sleep sense into our nurse call system and how we do our care, we were able to alleviate that ethical dilemma. It was very cost effective. We weren't going and buying, $4,000 to $10,000 beds for, all of our residents and that. But we really feel that it contributes to that holistic person-centered care that we really value. And lots of times it can be hard to balance with staff needs and that too, and supporting staff and that. So I think that made a huge difference for us as a team in that. And we haven't had any real pushback on it from staff or families. And I have used it in terms of investigation sometimes when people have falls and that if you're doing rounds and you're walking around, you don't necessarily know when the person fell if they don't have any kind of fall detection in their room. And so you're hoping they haven't been on the floor for a long period of time. And that's one of the things that families often ask us, how long were they on the floor? That concern, and we have the same concern. But when you're looking at 1 to 2 people, they can't be everywhere all the time. So I'm going to stop talking for a while and pass it over to Mary.
Okay, hi everyone. Good afternoon. Lisa was talking about falls. So we have to understand also that Langley Lodge building is like 50 years old. So the system that we have is quite old. Now, how can we integrate a technology to an old system? So our system is quite similar to probably a lot of the care homes. We have a call bell system that we're using for them to for residents to use for call bell. That call bell system has two outlets. One is for the call bell and one is for the bed alarm, which is the alert call bell. So what we did is that instead of connecting the bed alarm to that system, we actually utilize the sleep sense sensor to connect and gives us an alert. So what happened is that if a resident is off the bed, that sensor actually looking at the weight of the bed. So when there's a change on weight, it would create an alert. That's how it, in terms of the mechanism of it. So that's how it creates an alert. And so just like with call bell, when you use a call bell, it would send up an alert to the care staff phones. It's the same with sleep sense. However, we have 139 residents. We do not give this kind of setup to all 139, then you're gonna have multiple alerts happening at the same time. So we actually created a different category. So we have the high fall risk and the low risk residents. So the high fall risk residents are actually being assessed by the physiotherapist that they are considered a high fall risk. We also do a lot of assessments by the nurses to identify if they are high fall risk if the physiotherapist is not available. This residence has probably multiple falls that is happening. That's why they are considered in high fall risk category. Then we set up the system for them so that when they try to stand up or try to go to the bathroom, the sensor will automatically do an alert to the phones. Now, there's two types of alerts that we can see in the technology. And one of it is that the one on the phones that I was talking about earlier, and the second one is on its website. So as you can see here, this is what it looks like. Like an hour ago, got off the bed at 12:30. Now, 52, this room number doesn't mean that it is a high fall risk or low risk resident. It's just gonna create that alert for you. Um, and there are different types of alert that we can customize if they get up too frequently, do you want an alert for that? If the resident has not returned to bed at a certain time, do you want an alert for that? Or if you want to go to be off the bed, do you want an alert for that? In my experience, I have worked in different care homes that they are using as like a pad to create an alert. I'm not saying it's bad. It's actually understanding if that technology is actually creating more workload or not. So that is something that I realized from the technology is that we have to integrate it to a lot of the systems that are already in place, especially to the routines of the staff. So this is not a this is not a new thing for them. It's just creating an alert for them, which is going to be easier. So this is how it looks like on our end. If we actually look at Langley Lodge profile and the hourly alerts, you can see how busy it is throughout the building for people getting off the bed. So that's for the falls. And again, it's something that we also recognize as one of our quality indicators for really good person-centered care. On the next slide, we are um, if you don't mind, there you go. For the better quality of sleep and positively impacts quality of life of residents. So we talk about sleep pattern, but really we know that older adults have sleep disorders, and that is just as per research. Now, sleep data is we want to understand it better because we would know that can be a major factor for a quality of life because the more we understands it, the more we can actually understand also how it impacts the life of the resident. So for example, if the resident is not sleeping a lot, when they wake up, they're going to have a low concentration, very poor judgments, and that would contribute to falls. And that is something that we have to understand more as clinicians and as leaders, is that there are multiple things that are happening in our residents' lives that really does impact not so that is something that we are looking on with our team. So as you can see here, we kind of like want to see the quantitative data. You see, nobody in my family can tell me if I have a good sleep or not other than me. Same thing with our residents. We can never say if they have a good sleep or not just because we know they're sleeping. Only them that they can tell, and somehow this technology can really support us in that. So here the sleep score is 86 and the resident stayed in bed for 11 hours. That's a very long time, but at least we know how long it for them to sleep in bed. So you can see then the heart rate in bed is their average, their breathing rate, and at the same time, better understanding really on how they sleep and how can impact their daily activities. Now we're gonna go to the next slides. Lisa was talking about workloads. So the previous two slides were talking about the residents. Now we're gonna talk about the staff. So the staff in Langley Lodge profile, one staff is equivalent to 26 residents. Now it might be the same to other care homes, and that we acknowledge because once you get a night shift, you have skeleton staffing. If one called in sick is very hard. That is very hard for the staff to work on. So somehow we have worked with Top Tech and really creating technology and leveraging it in terms of routine. It's very common in long-term care homes that we do round check just so that everyone we can see all the residents, and it also helps the staff. It's more for the staff as well to understand that they are working and making sure that residents is away, is sleeping, and they're not having problems. As you can see here in the picture, these are the times that they do actually round check. So we do hourly check. And I will just show it again for the next slides on how does it look like on some parts. So if we go to the next slides. So we do virtual check and in-room check. So as Lisa said earlier, we created a policy. So policy makes changes sustainable. So this policy, at 5 o'clock, we asked the staff to do in-room check the moment they start their shift and before they end their shift. So at 5 o'clock, it's between. They did a virtual check to 9 residents and they do in-room check to 6 residents. It's because the system is telling them to do in-room check because the system cannot detect any heart rate or breathing rate of the residents. So the staff would need to go and check those 6 residents. So 207 is sleeping, 214 is a hallway. So it actually asks the staff to create or to document what's happening with the resident. A hallway wandering, and then someone is on a wheelchair. So really, it really helps the staff to document it better. And also for us nurses, we can actually check on these things because it's in the system. We can easily audit it if there's something that if the staff needs it. For example, the staff needs at night that they have a really heavy workload, a lot of residents are awake at this time, then we would adjust the routine to address these concerns. So it's really helping us as well as management to identify these concerns better and really support the staff more in a much more not so much with subjective but much more objective data. We'll go on then to this slide. So really, not all this technology also address our dilemma that now residents now have access to it. So one thing I learned is that in healthcare, we should make it available for everybody because then it's fair and equitable. It's cost effective. So that is something that is very important for us because then we are not spending so much money on things that can be cheap. Like it's just the same thing with technology. So we are really happy to work with Talk Tech, especially in making these changes over time that really supported the staff. So I think Lisa will be talking about this one.
Thanks, Mary. Mary has been a great support. And one of the things I didn't say earlier in terms of when you're doing an implementation of technology is the importance of having champions, really having resources dedicated, front loading some resources so that you do a good implementation. And you've heard Mary already talk about the importance of doing things sustainable. I think many of us in healthcare have been asked to do things and wondering how it's sustainable, and people just want data or they want us to do it for a short period of time, which is quite draining and hard on staff to add on to their workload. So sustainability is really important. For some of the results we found was that for our frontline staff, our direct care staff, they now were not, like we said, in that dilemma. Everybody had access to this sleep sense, and to we weren't having to make choices. Does Justin get it today? But yet, now he's not falling. We take it and we give it to Simran, and then next thing you know, Justin's falling again, and it's like, okay, that was very stressful, and we were physically wheeling beds from one room to another, the ones that had the alarms in that. So not only just the reduction of workload at night, but the workload in terms of moving beds around physically to meet the needs of changing residents. And, that was when we were getting, pre-COVID, maybe two admissions a month. Now we're closer to 5 or 6. So that's 3 times the workload, pre-COVID and that. But we've also used this data for our families too, and we've integrated it into our care conferences and into our medication reviews and that. And we used it when we were doing a project on antipsychotic use. And lots of times what we were noticing was that our nurse practitioners and GPs were prescribing antipsychotics for bedtime. And and it was really difficult for us to differentiate, like, is this for sleep? Is this for, bedtime care so that they're not, resistant to care and that. But we could actually show now whether or not, if it was prescribed for bedtime, and that whether or not it was effective or ineffective in terms of their quality of sleep. So it gave us quantitative data for that. And then we could also look at the bed exiting. What I didn't like, there's so many things we've gained from this that I never even dreamed of. So when staff say, oh, it's really busy at this time, we can actually see the trend of exactly, on average, how many people are up at what time, like how many people are getting up. Is it, we've got 20 people up by 8 o'clock, or is it, we've got 5 people up at 5 o'clock and you're like, what are they doing up? So it's just given us a whole bunch of information to look at person-centered care for all the residents we care for. Operationally, it's helped us with the workload and that, but we have had to be very conscientious about alert fatigue. And I think we've all heard that word lately, is that, there's an alert from the nurse call, an alert from sleep sense, an alert from this or that. And so making sure that the alerts are customized to what do we really need, and what information, and making sure that if we're getting alerts, we're doing something with it. We're not just getting alerts for the sake of getting alerts, because lots of times staff have to go in to press a button in the room to turn off an alert and that. And like I mentioned earlier, it's helped me with an investigation. I don't know about you, but when I worked night shifts, you often lost track of time. So if somebody said, what time did you do that? I might say, oh, that was at 2 a.m. But would I bet my life on it? I don't know, because time gets away from you. And especially if you haven't documented it in real time and that. I love that it's complementary to our nurse call system. We're not piling on a bunch of different systems. It's integrated. I mean, I'll be honest, we have been working through some issues with when one system goes down, how does it impact? But if we wanted to, Sleep Sense could work independently of it. At an organizational level, because this leveraging of technology and of Sleep Sense went so well, is that as an organization, we've actually made more of a commitment to looking at technology. And you'll see everywhere, use of technology to help with this, use of technology. And we often hear about things like in acute care, robot to, do eye surgery or whatever. And when I first was in healthcare and people would say, technology in long-term care, people thought of little robots, and it's like, mm-mm. And one of the other things I just really want to emphasize, we are not doing this to replace any staff. This is to enhance what our staff do. We will never try to replace anybody. We're not trying to save money. We are a nonprofit. All of our money goes straight back to our residents and that. So, that's our value system. But we also didn't want to add something where families would have to purchase something. I mean, we do ask families to purchase hip protectors. They usually, do alarms for wheelchairs and things like that. We didn't want to be put in the place where we couldn't afford, 139 alarm beds, and then saying, if you want that for your loved one, no different than a Roho cushion or whatever. And we all do that differently. I do understand that. So I think with our staff, what was really great was that it changed my perception, and it changed staff's perception of how technology can be an enhancement to what we do versus trying to take over anything. I think we talked about this already a little bit, but that champion being aware this is change management. It's going to take time. The one thing that I think made a substantial difference with this is we actually wrote new policies. Like I said before, we didn't have policies on rounds. It was something that we all knew we did. We didn't have policies on, how to use sleep sense and what our expectations were of night staff in terms of doing rounds or documentation of rounds and that. And so we've integrated the education now with our new staff and that, just like, when we changed point click care, it seemed like there was a lot of training, and now it's just become more integrated in that it's just a natural part of our orientation and that, and when people come to our home and work with us. And so one of the things, this one here, building internet accessibility, that was something we had to do, and we had to put up more boosters and that. But we found that even with our EMAR, that I don't know if some of you have experienced this, where we have some what would you call it, like not a black hole, but like dead spots in our building and that. And we're a brick building and that. So you learn a lot about, especially when you're in an older building. And, we often think of technology and purpose-built facilities, but we're like your 50-year-old old building. And if we can do it, anybody can do this kind of stuff. But I think, some of you may know our CEO, Ali Devji, and he's very committed to, contributing to seniors' health and senior care and leadership. And so he's been a great advocate for the work that we do. Is this me too, Mary? Okay. So in the short term, we are using some pressure injury. So, we don't want to be big brother, but if we wanted to see if we can see movements in the bed. And I think Mary might have pointed that out, or will be pointing out that in some other slides, where we can see when people are repositioned or if they weren't repositioned. I've already talked about how we did our antipsychotic medication study on looking at, those antipsychotics prescribed specifically for sleep and that last year, and that was with Healthcare Excellence Canada, and that was quite unique in that. And then, going forward, we're just keep working on our quality indicators, just like everybody else. We're still trying to reduce the risk of falls, look at the quality of sleep, look at our antipsychotics and our responsive behaviors. And I think most of us can relate to sleep. When we did this presentation with another group, we had an expert from Ontario talking about sleep. And I think sleep is of interest to most of us. We've all had periods of time when we haven't been able to sleep, or we see how lack of sleep can make a difference in how we show up, how we behave, how we think, and all of that. So looking at all of that. Um, and then I think for us now, we're still working on using that quantitative data to better know our residents and that, and to use it in a way that improves their quality of life. And I'll pass over to Mary, and she's going to talk to you about a few case studies we have.
Yes, and on top of what Lisa said, we actually utilize this data to talk about during care conference, medication review. Recently, we have mental health team to come in and we present those information to them. With doctors, they would rather see objective things rather than what the staff think, because then they are actually making decisions that is it's a reflection of what's really happening of the resident. So one case study that we did was that I think it was on 2022 when it was during the first year that we are actually recognizing the importance of with this technology in our decision making. We have one resident that is living in Parkinson's disease and has expressed distress regarding the progression of his condition, diagnosed with depression, anxiety, and had a medication that was discontinued on August 10, and it is aripiprazole. Is an antipsychotic, and again, usually a lot of the doctors would reduce this medication because they don't see the value of it, or maybe they do not know why this resident has medication and the resident is coming in with this bunch of medication that the doctor was not aware of. It's just one of the information that fell crack into the system. As you can see on the side of this picture, you can identify the summary of the report of this resident. He frequently gets up at night, but the average is three times at night. Good sleep score of 71, and that is his baseline, given that we took it for a long period of time. And yes, we can actually do a summary with the date range, so we can figure out what happened prior to discontinuing of the medication. Now we go to the next slide. So what we have observed, so what's the concern was that you have a client has a history of depression, has anxiety, has Parkinson's, and now one medication was discontinued just because the prescriber says let's cut off this medication and discontinue what he actually needs of what they think that the resident actually needs. So, although night care staff have noted that he appears to be asleep during their rounds, we identified a discrepancy. So, what happened was that prior to the rounds that we're doing, we have paper to actually see if they're sleeping or not as part of our sleep assessment that is been implemented way before. So the staff says, you know what, he was sleeping, so he was sleeping all throughout the night. The resident was telling the staff, no, I did not have a good sleep. Now, the problem with that is that this nursing staff or the care staff thinks that, you know what, this residents probably forget that they slept, or he has dementia and they probably don't know what they're talking about. And that is very common in a lot of our practice. So, and then we recognize, you know what, we have sleep sense. Let's look it up and see what are the objective data that is that reflects the resident. So that is something that really changed our way of thinking, because then we're just not very subjective about what we think that the resident sees or what we see, but rather what's really happening and a reflection of what the residents experience. At this time, also, the resident expressed of pursuing maid. We did a lot of, the resident has been telling the staff that there's a suicidal ideation, and that is something that we want to be much more alert on those things. So we have been working out with the staff about it. And after that, connecting to the residents, having all this data, we connected with the team and now we can understand it on the next slides. So we did a lot of assessments, we did a lot of physical observation, and when we actually did months and days and weeks of looking at this data, because we also want to recognize, is it just something a withdrawal? Because you have a medication that has been used for a long time, you need to reconsider different factors that might impact it. Is it the withdrawal, or maybe it's just UTI, all those different things before we can actually look at the medication, because as clinicians, it's one last thing in our mind. Medications is not something that we have recognized that might really make an impact or factor in, because we are just so used of medical diagnosis as part of those reasons why they're like that. So as you can see, the average has gone down to 58, and that is something that was noted during our conversation, is that this resident is sleeping well before, and now you have someone that has a really low sleep score. Now you have someone that gets up at night from 3 to 10 at night, and that is something that we did not recognize, because maybe when the staff was looking at the resident, that is the time that he went back to bed. And that is something that we do not see unless we actually see that actually we use the system. In November 2022, after getting all this data, we present this to the MRP and said, you know what? This is what our objective data, this is what the staff connected with the resident about. and she re-prescribed aripiprazole. And that is something that is very important in our practice, that we are actually looking evidence-based and not just what we think and what we see, but rather what really reflects on the resident's experience. And if you go to the next slide, please, Lisa. This is not just what of the case study that we have in the lodge. There are other case studies that are ongoing that really talks about sleep and how that it impact the quality of life of the residents. At the end of the day, our aim to be it really is about seeing the person as a whole, not just what we think that they need, but really what is happening to them. And this technology is actually really helping us to have better decision making, especially our nurses, our care staff, and even the doctors. So I hope that really helps up and wrap up the things that we have done with the lodge. Um, I think, Lisa, if you want to add anything.
I just wanted to say, I'm just sharing here this slide. Talk Tech has been working with other partners across Canada, that are, and universities and that. So it's not just kind of a fly by night kind of, oh, this works right now. There's a lot of research that continues. Fraser Health, with the work that's been done, has decided to implement Sleep Sense in 3 of their own and operated homes, which is good to see. And there's been a lot of success, I think, there with that too. And if anything, we kind of share, and I think that's what I would strongly encourage all of us, is to share what works, right? That's the great thing about BC Care Providers, and with the upcoming conference, is that we work together. We're not all trying to learn everything on our own and alone and that. So, Talk Tech, they have a great team. And if you want to reach out to them and that, you'll see that they've got their website and that. And I would encourage you to look at their website if people are interested. And then just a big thank you to all of you, but also a big thank you to Jessica Yang, who helped us to kind of see what we could do and worked with us. Not, she didn't sell to us, she worked with us. And that makes a big difference in terms of vendors. Justin, you had your hand up. I don't know if you used to have a question or not.
Oh, I was setting up a clap there, but I didn't have a
Oh,
question. But no, that's a good segue. Really good presentation, Lisa and Mary. That was
thank you.
I knew a little bit about Talk Tech, but that's really reinforced kind of what I knew about it in a positive manner. Um, Obviously, the impacts for the residents are amazing. One thing that really stood out to me was the 25% savings in care staff at night. And obviously, for nonprofits, it's a little bit different than private organizations. But I'm wondering if you guys have quantified that into like an amount of what that would be for savings, as well as were you able to reposition those hours at night into perhaps some other areas that maybe needed additional care hours? Did that help Langley Lodge at all? Like, I'd just be very curious, and how that positively impacted not just the night, but the daycare as well.
Mary, do you want to take that? Yeah.
Yeah, so how can you're thank you for that wonderful question, because that is very common to a lot of long-term care home. Like, how does it really impact the staff? If I will tell you, we have less night shift that called in sick. That caused because we're talking about workload. Workload leads to burnout. Burnout leads to sick calls. And sick calls, really, they don't want to work anymore in long-term care. And that is the reality in long-term care right now, is struggling to find staff, especially to work at night. Now, for the staff to see this technology improving the workload, I will tell you right now, I don't have anybody in our nurses, in our care staff that called in sick at night, because they know that they have a technology that will support them during their shift. What really supported them the most is that they're just focusing on what is important during their nights. Now, night shift is about prioritization. What are the things that they need to prioritize? Because we only have one staff in 26 residents. So if one person is calling, um, they can easily go to that resident, especially if they're high fall risk. It would reduce falls because once you have fall, then you have to take care of this one resident for 15 or 30 minutes, and now you have more residents that are waiting for you to work with or to support with. And we have identified those things. That's why for them, it has been very helpful for them to reduce those workloads. And for them as well to go and check the resident. So what happened was that, especially in a shared room, you check one resident, another resident wakes up. Now everybody is awake. Once everybody is awake, then it starts rolling down the hill. And for me, working as night before, I realized how important it is to actually create an environment that is not noisy, because I can never sleep in a noisy environment as well.
Yeah.
So hopefully that answered your question, unless you have more
I'll just
clarification.
add a little bit, Justin. We haven't been looking at terms of the time savings or the cost savings. We haven't put it to that degree. I suspect that is something people will look at. I think it's more about, for us, it's been more about the better management, and the fact that, if you can do a virtual check in 2 minutes, and think about that compared to if you had to walk around to 26 rooms and you can't just open the door. That's not really a true round, right? How long would that take? And then if you wake somebody up and all of that. But I think it would be interesting. And I do see now that Jessica is on. I don't know, Jessica, has any of the other research studies tried to put it in a cost savings kind of perspective?
Thank you, Lisa. Thank you, Mary. That was really great presentation. So to this question, we actually tried couple of years back and to quantify or have a way to calculate the cost saving. I think at that time that was in our project with Bria in Ottawa, there was a kind of calculation from night, just to take a sample from a night saving, and that turns out to on a home with, I think it was like 70 something residents. Um, it was around over $50,000 per year, just on that particular area of saving. We never published it. Honestly, and then I guess people have different way to interpret it, how this saving, how this cost, be deduction would look like. And later on, when we work with other organizations and, Langley Lodge and many not-for-profit or profit organizations, I found out they're more focused on, as Mary said, the reduce the stress level or improve the efficiency rather than the dollar amounts. But I think that's very, very good question. And then I just we don't have anything published yet. But
Yeah.
hopefully they gave some idea.
Something
No,
for us to think about, yeah.
the only reason why I asked that is like obviously is to improve the resident outcome and employee outcome. But when I think of like how can this be adopted more often or more likely, and sometimes money can certainly talk to different folks and different outcomes. And so I just
Yeah.
wonder, like, that might be a positive story and really cool that it's reduced sick time. That's another kind of cool asterisk. I'd be wondering what that's done. And it's really, I guess, that aligns with your vision of being an employer of choice, and resident of choice. So yeah, that makes sense. That's very cool. Great presentation.
Thanks, Justin. Any other questions or anything in the chat? I didn't see anything. Did you, Simran?
Yeah, no, I think everybody was paying attention to the to the presentation itself. But thanks, Justin, for chiming in and asking your question. If there are more questions, we have a few more minutes with Lisa and Mary. So I encourage all of you to ask any of the questions that you might have. While other people might be, thinking more about these questions. I did have one question. Do you share the sleep data with the residents and their family as well? As like, oh, this month you scored an 86 or this month you scored an 88. Is that something that
We
happens?
we do if they need to, because
Yeah.
sometimes data is very um it's not good if it's not asked, because you have to have a good clinical background to really understand that.
Right.
We do offer it during care conference, talk about the sleep and everything, but we don't really go in depth about it, because unless they are interested in understanding the data, because sometimes once you get to know these things, you often get anxious about, like, okay, now I have do not have a good sleep. It depends. And
Yeah.
again, as long as if the family needs it, we do offer it to them.
Yeah.
But the doctors do want to see it better, because they understand the data better than, and then they're better in making decision making, especially when the nurses ask them for a sleeping aids. We tell them, like, you know what, this is actually not working, because maybe this is just the resident's baseline. They are just not a good person, like doesn't have a really good sleep at night.
We actually do have some residents who are diagnosed with insomnia. They came to us with insomnia. But I was going to add to what Mary said, is that if we share the data, it's more about the trends. And that's the great thing about this technology. You can see a 2-week trend, like you can look at the last 2 weeks, you can look at the day. Lots of times, if somebody's had a really poor sleep, and normally we look for people to have, a sleep score of 80 or a little higher than that. But, the fact that we would share, or if there was something going on, and their loved one, usually if there's a change in status, that's the kind of language that's used in long-term care. Lots of times you can see also there's a change in sleep or something else going on. It could be that a person has a UTI, or they just had surgery done, or we do really look at the data closely during that first few months of when a person is admitted, and that it really lets us to get to know a person's patterns quite quickly, and just to actually quantify how challenging it can be for people moving into long-term care. There's a lot of emotions, but there's also a lot of physical stuff that, when people have our complex care and have multiple chronic disease, and that we see. But I think what's really interesting is, through understanding it right from the beginning, to see that people, and I know Jessica and I has talked about this with other studies too, they had the almost identical results to us, is that 35% of residents' sleep improved within that first 2 to 3 months. The other thing I forgot to share was that, our rounds on night shift now, 65% of our rounds are now virtual. So if you think about that, if 4 or 5 rounds are now being done virtually, let's say 5 rounds to now 10 minutes, how long would that have been before? And I use the term non-value added, not because it's not important for us to do to ensure the safety, but lots of times you may not be there at the exact moment that somebody needs you, whereas this technology tells us exactly and alerts staff if they're moving around in their bed a lot. They don't even have to get out of bed. So it alerts us and gives us information to be more proactive. I think I seen something in the chat there, Simran.
Yeah, I shared your email
Oh,
IDs with the
okay,
attendees.
sure.
So
Yeah.
any other follow-up questions can be directed to Lisa and Mary for their expertise. And then thank you so much, everyone, for joining us today. I certainly learned a lot. Thank you so much, Lisa and Mary, for sharing your insights. That was extremely valuable. And then, as I mentioned earlier, the slides from this webinar would be shared with all of the participants, and then with a recording as well. So yeah. Hope you have a great rest of your day. Thank
Yeah.
you so much. Have a
Thank
nice
you for
week
giving
ahead.
us the opportunity to share. Okay. Thank you.
Absolutely.
Bye,
Thanks so much,
everyone.
Bye bye.
everyone.
Bye
Bye.
bye.